Good evening all. Today's topic will be based on intussusception. The presentation will include a basic introduction towards intussusception, the pathophysiology of the intussusception as such, and we will go into the details of the classification, the various clinical presentation, and how to diagnose a case of intussusception. Then we will come to the management part, and then we'll discuss regarding the complications and also regarding the outcome. Coming to the introduction, the term intussusception was derived from the Latin words indus, which means within, and suspiam, which means to receive. So we know that a proximal bowel is invaginated into the distal bowel. The invaginated bowel is called as the intussusceptum, and the recipient bowel is called as intussuscipiens. It is the second most cause of acute abdominal pain in infants and in toddlers. The diagnosis and treatment requires a combined effort of pediatrician, the radiologist, and the pediatric surgeon. The incidence comes around 1 to 4 per 2000 children, and it shows a male predominance, almost in a ratio of 2:1. And 75% of them occur within the first 2 years of life. A seasonal variation is also shown with presentation of intussusception as such. It is more common in the months of May, June, and July, especially in the rainy season, because there is more chance for a viral infection during that time. And preceding viral infection is noted in almost 20% of the total number of cases of intussusception which presents to us. Coming to the pathophysiology, initially there will be a prograde peristalsis, and there will be intussusception of the proximal bowel into the distal bowel. This leads to angulation of the mesenteric vessels, which in turn leads to a venous congestion and mucosal edema. This in turn is followed by blood-stained mucus, which passes through parrectal region, and patient can present with the passage of blood-stained mucus also. And in turn, this cycle leads to formation of ischemic necrosis and bowel gangrene. Another pathology which we need to see is that in some studies they have noted that there is a white line which is known as a pressure line, which is recognized in that ischemic bowel, and if such a white line or a pressure line is seen intraoperatively, then that is an area of ischemia. It is an indication for an ischemia, so that it is in turn it's an indication for considering resection anastomosis of the particular bowel segment. And in case of undiagnosed cases, if it is not diagnosed early and if it is left alone, then there is chance for sepsis and death in the next 5 days. But sometimes it has also been reported that the intussusceptum might necrose off with automatic fusion of the bowel within, and it may pass off through the pass off in stool. Coming to the classification, it is basically classified into general, specific, anatomical, and other variants. The general classification includes division into permanent and transient intussusception groups. Permanent intussusception is the most common entity, accounting for almost 80% of the cases, and transient intussusception, which involves mostly small bowel, it accounts for almost 20% of the total number of cases. Another classification is based on the specific etiology, whether there is a pathological lead point or not. So mostly 95% of the cases won't have a pathological lead point, but 4% of them can have a pathological lead point, like duplication or Meckel's divertillum or a polyp. And 1% of the cases are due to postoperative, which happens in the postoperative period, which presents as a small bowel obstruction following a laparotomy. And another classification is anatomical classification based on the anatomical segments which are involved in the intussusception. So the predominant one is the ileocolic, which accounts for almost 85% of the cases, followed by ileocolic, that accounts for almost 10% of the cases. And this is followed by colocolic intussusception, which accounts for 2.5% of the total number of cases. And small bowel intussusception is also seen, which can be jejunal or ileo-ileal. It accounts for almost 2.5% of the total number of cases. And another entity which is found is that there can be intussusception around the indwelling tubes. For example, feeding gastrostomy or through the gastrojejunectomy tubes, there can be intussusception with the tube acting as a lead point. Then others include a neonatal intussusception or recurrent intussusception, which accounts for 5% of the cases. Coming to transient intussusception, so most of them are incidentally detected when the patient is being analyzed for other pathologies, and length is usually less than 2 centimeters, and predominantly it involves small bowel. They are mostly asymptomatic, and out of the symptomatic ones, 6% of the symptomatic ones have pathological lead point. So that has to be intervened. So in that case, we need to intervene if there is a pathological lead point. Otherwise, the usual pathology is that there is spontaneous reduction in majority of the cases, so we can wait and watch. And if that intussusception is persisting, then it is an indication for intervention. Coming to the specific classification, and predominantly I told that they are idiopathic, and lead point is usually a thickened Peyer's patches. So Peyer's patches are mostly predominantly seen in the ileum. So whenever there is an viral prodrome or a viral infection or a gastroenteritis, there can be hypertrophy of the Peyer's patches, which in turn can act as a lead point in most of the idiopathic cases. And viral etiology as such, it is pointed towards two viruses. One is a rotavirus and the other one is adenovirus. Even a particular rotavirus vaccine was abandoned by FDA, and it was like permission was not given to continue with the vaccination for rotavirus in the US, because it was found that it was significantly associated with post-vaccination intussusception in the children. And another etiology is a feeding pattern. It is when you consider the human milk as a reference point, soy-based milk formulas are found to have less incidence of intussusception, but cow's milk-based formulas are found to have more incidence of intussusception. Now coming to the pathological lead point, the incidence usually increases with that of age. And sorry, with one episode of recurrent and a pathological lead point, if you consider, and with one episode of recurrent intussusception seen in almost 4% of the cases, and multiple episodes of intussusception accounts for almost 19% of the cases. The major cause of a pathological lead point includes an inverted Meckel's, a polyp, or a duplication cyst, and the minor causes includes factors like periappendicitis, stump, persistent appendicular stump, inversion appendectomy if it is done, that can also act as a minor pathological lead point, mucocele of the appendix, then various neoplasms involving the bowel, vascular malformations, ectopic pancreas, even sutures, trauma, and henoch-Conlin purpura. And most pathological lead points manifest as ileocolic intussusceptions, and which accounts for almost 40% of the ileocolic intussusceptions. So 40% of ileocolic intussusception will have a pathological lead point. And most intussusceptions are caused by PLP can be reduced by enema techniques. Ultrasound and reduction enemas are the cornerstones of diagnosis of the lead point. And per se, ultrasound is having much more or a better sensitivity to identify the lead point than reduction enemas. And higher imaging always has got a limited value in the diagnosis of the same. Now coming to the post-operative intussusception, it accounts for almost 1% of the cases. And it is the third most common type of intussusception, and due to it is accounted due to excess bowel handling in long abdominal procedures. Mostly it is mostly what we see are small bowel intussusceptions, and it can present as small bowel obstruction in the post-operative period. So if you are seeing if you follow a patient of a laparotomy, if he is in the post-operative ward, and if child develops a small bowel obstruction, one thing which you always need to keep in mind is that a possibility of an intussusception. And 3 to 10% of the small bowel obstruction can be due to intussusception. And predominantly mainly ultrasound is diagnostic, and majority requires operative reduction. Recurrences are rare. Coming to interlinked tubes as a pathology for an intussusception, mostly they are seen with the gastrojejunostomy tube feedings, which accounts for 16% of the cases, and the majority are transient. Rarely there is need for surgery. Predominantly there will be a retrograde intussusception which can develop along the tube towards back towards the stomach, and it can present as a high small bowel obstruction. So it requires a in case of high small bowel obstruction, it requires a surgical management rather than waiting for a conservative approach. Coming to recurrent intussusception, and recurrent intussusception, if you consider the incidence following a barium enema reduction, it is around 8 to 15%. And if you're doing an ultrasound guided hydrostatic reduction, it accounts for 5 to 20%. There is 5 to 20% chance for recurrence. And if you're doing a fluoroscopy guided pneumatic reduction, again still it is the incidence of recurrence is 5 to 15%. And ultrasound guided pneumatic reduction has got an incidence of 6 to 7%, which is slightly less when compared to the others. And following a manual operative reduction, the incidence of recurrence comes down drastically to 3 to 4%. And following a resection anastomosis, it is almost nil. And most recurrences will occur within the first 24 hours. And about 70% have only one recurrence. And if you are considering recurrent intussusception also, since already once it has reduced, there is high chance that it will get reduced by a repeat pneumatic or a hydrostatic reduction. So they got a high reducibility rate of around 95 to 100%. And most children with recurrence will not have a pathological lead point, but possibility of a pathological lead point should always be considered when a patient presents to you with recurrent intussusception. And image guided reduction should be undertaken for any as a first modality of as a first approach, and in all case of recurrent intussusceptions. The operation should always be used only if it is irreducible and after an unsuccessful delayed repeat enema attempts. And if there is perforation from the enema, or if there is a clinical evidence of a pathological lead point. Coming to neonatal intussusceptions, which accounts for 0.3% of the intussusception, they are infrequent and can mimic necrotizing enterocolitis. Because due to bowel gangrene, there can be pneumatosis intestinalis. And especially if there is a delay in diagnosis, it can go on to gangrene and in turn lead to mortality. And mostly it requires a surgical management, which is a resection anastomosis. Clinical features, we will come to the clinical features of intussusception. There are classic symptoms and classic signs with which the child will present to you. The classic symptoms include abdominal pain and vomiting, and child will be irritable. The classic signs include an abdominal mass and bleeding PR. And all four cases can be, all the four features can be seen in almost 30% of the cases. Otherwise, it will be a mixed presentation. Usually, most of the presentations, almost in 20% of the cases, they will be having a preceding diarrhea history. And rarely there can be a prolapse of the intussusception, and the patient might present with a prolapsing mass via rectum, which is always a grave sign. And the patients will have fever, tachycardia. If the patient is having a fever, tachycardia, and hypotension, you should always think about a possibility of perforation and bacteremia. Coming to the investigations as such, the first modality of investigation, when you consider is a plain X-ray abdomen, and but the role of plain X-ray abdomen is controversial. And the signs basically mainly includes meniscus sign or target sign, which will be seen in a contrast study. And if you consider a plain X-ray as such, there can, if you see towards X-ray on the right side of the screen, there can be a soft tissue shadow on the right side with bowel gas shadow on the left side. So there will be absent cecal gas shadow also. So these are non-specific findings, and the ideal investigation of choice is always an ultrasound. And so mostly in as an investigative modality, the plain X-ray can be easily omitted in infants suspected to have intussusception because it has also got risk of radiation. So ultrasound is the most preferred investigation. It has got 100% accuracy in hands of an experienced sonologist. Finding will be a 3 to 5 centimeter diameter mass as shown in the picture here. It will be a 3 to 5 centimeter diameter mass with a target sign. You can see a target sign or a donut sign here in the ultrasound. There will be initially a hypoechoic rim followed by a hyperechoic area in the middle. So that shows the telescoping of the bowel. The advantages of and also using an ultrasound, we can always assess the viability by putting it onto a duplex mode. The advantages include that ultrasound is always portable and it doesn't have a radiation exposure and can detect a pathological lead point also if at all it is present. And it has got higher sensitivity when compared to contrast enemas. The other cons of USG include it cannot predict well if the intussusception is already necrotic or amenable to a non-operative reduction. If positive, then next higher study, it has been stated in some series that if at all ultrasound is positive, then always you will have to go for a higher study. That is usually you will be doing both a diagnostic and a therapeutic pneumatic reduction. So always a higher study which includes the radiation is always required after an ultrasound also. And in highly suspicious cases, directly a therapeutic enema can be tried rather than going ahead with the ultrasound. So these are the major points which are stated in the recent literature. And regarding role of higher imaging like CT or MRI, usually they are not recommended. And contrast cinemas were initially used before the advent of ultrasound. Before it was widely, now ultrasound is widely available. So contrast cinemas, they have only historical importance now. So contrast cinemas as such, they can be both diagnostic and also therapeutic. The disadvantages includes that it is a semi-invasive procedure and requires a radiation exposure. So when compared to the contrast cinemas, ultrasound is better. Ultrasound is better and can see for other pathology. That is, a pathological lead point can be better delineated on an ultrasound. And other abdominal pathologies can also be seen by using an ultrasound. Coming to the treatment as such, the initial treatment begins when the patient comes to you. You need to evaluate the patient thoroughly so that you don't miss an intussusception. And usually the sensitivity of a clinical examination comes around 50% when compared to the other investigative modalities. And because most of the time the children will be present you with abdominal pain and vomiting. Child might be dehydrated, so you need to do a proper fluid resuscitation of the child. And after that, if recurrent vomiting is there, you put an NG and decompress abdomen and start on broad spectrum antibiotic. Because suppose if the child is coming after if there is a late presentation and all, there is always chance for a transmigration of the bacteria across the gut, and it can in turn lead to bacteremia and septicemia. So always better that you start off with a broad spectrum antibiotic whenever the child presents to you. And definitely you will be taking the child for an intervention. So simultaneously, when you are putting off a cannula, you send the blood for all the investigations, and an arrangement also has to be made. And the dictum is that you always attempt for a non-operative reduction if the child is a stable infant. So if once the child is hemodynamically stable after fluid resuscitation, you can attempt for a non-operative reduction. The modality can be either a hydrostatic or a pneumatic reduction. So if it fails, the dictum is go ahead with a laparotomy. Go ahead with a laparotomy or laparoscopy and manual reduction with or without a resection anastomosis, depending upon the intraoperative finding. Coming to the non-operative management, steroid therapy, non-operative management mostly includes for transient intussusception that we can observe the child. And in cases of henoch-Conlin purpura and all, we can always try a trial of steroid therapy and observation. And if it is not reducing initially, then reducing spontaneously, you can go ahead with a pneumatic reduction. And non-operative management can be used in stable patients with bowel thickening as lead point, especially in case of lymphoid hyperplasia or henoch-Conlin purpura. When you consider henoch-Conlin purpura, 13% of the patients can develop intussusception, and predominantly it will be ileo-ileal followed by ileocolic and then small bowel intussusception. Jejunal intussusception. The predominance of small bowel involvement is due to the pathological lead point being an intramural hemorrhage and edema in case of henoch-Conlin purpura. And enema reduction is feasible only mainly for ileocolic intussusception rather than for a small bowel intussusception. So if the ileo-ileal type does not reduce spontaneously over that 24 hours period, you will have to, and if the patient becomes symptomatic, then they will have to go ahead with a surgical intervention. Coming to the radiological reduction, the patient selection is of utmost importance because the basic dictum is that if the patient presents late after around 36 to 72 hours, and it is unlikely that it will get reduced by a pneumatic reduction, but there is still no harm in trying a pneumatic reduction. The contraindications for a radiological reduction hence includes clinical evidence of dehydration, shock, peritonitis, or radiographic evidence of perforation with free air. These are the absolute contraindications, and the predicting the outcome of a radiological reduction is not crucial because of the high success rates and low complication rates. So there is no harm in always trying a radiological reduction, provided that there are no absolute contraindications as mentioned above. And the current techniques includes pneumatic or the present technique includes pneumatic or hydrostatic reduction under ultrasound or fluoroscopic guidance. The hydrostatic versus pneumatic reduction under fluoroscopic guidance has a success rate. Success rate is more with pneumatic when compared to hydrostatic in most of the available series. And successful reduction rate ranges from 85 to 90%. Coming to pneumatic reduction, when you're doing a pneumatic reduction, you should do it meticulously. Otherwise, you can perforate the bowel. So, the critical pressure for a pneumatic reduction is 120 millimeters of mercury. So, ideally, you should advise your assistant that when the pressure crosses 80 millimeters of mercury, he or she should inform you immediately, and you should be more cautious when you are going above that pressure. And the critical pressure beyond which you cannot go is 120 millimeters of mercury. The advantages over hydrostatic reduction involves that it is easy to perform and it can be done quickly compared to hydrostatic reduction. It is less messy when compared to hydrostatic reduction, and when it is compared to hydrostatic reduction, it delivers less radiation exposure, because in hydrostatic reduction the reduction will be much more slower and it will take reduction will be so 1 second. Unlocked. It is unlocked. Sorry. Sorry. So we'll come back to the presentation. Um, so this is a picture showing the pneumatic reduction. Initially, when you do a pneumatic reduction, you do it with a 3-lumen Foley's catheter, and the one end of the Foley's will be connected towards the pump through which you will be insufflating air. The other end, the other channel will be connected to the pressure monitoring meter, and the third channel will be used to inflate the bulb of the Foley's. So when you're doing a pneumatic reduction, first of all, you need to initially stabilize the child, put an NG, and then position the CM properly. And before starting itself, you need to always keep a broad gauge needle aside, so that if at all perforation occurs, suddenly the child can go into vagal shock. So in that case, you will have to put a needle at the McBurney's point to deflate the abdomen, so that the bradycardia can be prevented. So initially position the child, and then a plain X-ray, a scout film has to be taken, which shows absence, which is as seen on the left side of the screen, which shows absence of the small bowel shadow. And then you insert the Foley's and inflate the bulb of the Foley's, but make sure that you don't damage the sphincter of the child. So the catheter has to be kept in the rectum, and then the bulb has to be inflated, and not in the anal canal. Otherwise, it will damage the internal sphincter. Uh, then after that, you start slowly insufflating the catheter with slow pushes of air, and you can see this has to be done under fluoroscopy, so that you can see the progression of the air and the reduction of the intussusception. If you see the middle picture, you can see the close sign of the intussusception in the ascending colon. So as the it's actually an air contrast enema. So if you are progressing with the pneumatic reduction, you can make out the reduction happening. And finally, the close sign disappears, followed by the gush of air into the small bowel. If you see the third and the final film, you can see that the small bowel is filled with air. So this shows that there is a complete reduction of intussusception. And you compare it with the first film, where it shows an absence of air shadow in the central part of the abdomen. There is no air in the small bowel. So this is how you do a pneumatic reduction. Now coming to hydrostatic barium reduction, as such, the entire procedure is obsolete now. Now no one practices barium reduction. It has got only historical significance. I'll just go through the details. And when compared to the pneumatic reduction, it is messy to use, and also the perforation may occur with a larger colonic tear. The same is applicable to the hydrostatic reduction. And there is increased peritoneal contamination and rapid fluid shift with hypertonic fluid going into the intraperitoneal compartment. And initially they used to use a rule of 3, that is 3 attempts. This is applicable for pneumatic reduction also. Maximum you can do it, you can go for 3 attempts of pneumatic reduction, and if it fails, it is unlikely to reduce with pneumatic, and you will have to convert it to an open procedure. And the duration of reduction should be 3 minutes, and the enema can, in case of a hydrostatic barium reduction which is done earlier, usually it should be kept at a height of 3 feet. And presently barium is no longer preferred. And an earlier complication which happened with the use of barium enema reduction was that if in case it perforates, it will lead on to a snowstorm appearance, and this will be persistent for the lifelong period because of the perforation and spill of barium into the peritoneal cavity. And there are certain methods which are documented in the various series to improve reduction. One was use of a sedation during the reduction, which in turn reduces the intra-abdominal pressure, so that less pressure will be required to do a pneumatic reduction. And there is little evidence, but there is little evidence for the same. And also another manipulation is a transabdominal manipulation of the intussusceptum, or the sausage-shaped mass as such, along with simultaneously with pneumatic reduction. And there is also a role for a delayed reduction enema attempt. But all these are having very little evidence is available supporting the same. Now, regarding the post-reduction care, those who are undergoing a successful reduction can be discharged after the first day, or the after 24 hours we can discharge the child once child passes normal stools. And always a pre-op antibiotic continuation after reduction is not indicated, because unless and until child has fever, or if reduction was difficult, there is no indication to continue the antibiotic. And at discharge, the patient should be aware of the relatively high recurrence rate after an enema reduction. Especially, you need to counsel the patient's bystander that there is always a chance for recurrence which can happen in the first 2 to 3 days. And in that case, they will have to be cautious, and they need to bring the child back to the emergency room or OPD. And the role of postoperative ultrasound and fallacies associated with, if you consider, usually in our institute we always do a postoperative ultrasound on the day 1, and if the reduction is completely successful or not, or whether it has recurred in the first 24 hours, we will know if we do an ultrasound on the next day. And the fallacies includes that usually after reduction the ileocecal valve region will be edematous, and sometimes the sonologist can confuse it and consider it as a recurrent intussusception. So this has to be mentioned clearly. The sonography is an important tool to reevaluate a previous partial reduction, and also to exclude a spontaneous reduction before attempting a delayed repeat enema reduction. Coming to the operative management, the indications include radiographic reduction. Indications, if you consider the indication, the radiographic reduction is contraindicated if the radiographic indication is contraindicated and has failed, or even if it is incomplete, and if there is evidence of peritonitis or pneumoperitoneum. And also if a pathological lead point is found, then directly you can go ahead with an operative management. But what we prefer is that you can always try for a pneumatic reduction, and if it recurs, you can go for an operative intervention. Then coming to laparoscopy versus laparotomy, usually it is based on the surgeon's choice, and also it varies from case to case basis. And the incision for a laparotomy is always planned according to the position of the mask. So once you give the anesthesia, the abdomen will become more soft, and you will be able to appreciate the mask properly. So based upon the location of the mask, you can plan the incision. Because in some cases of longer intussusception, sometimes the mask may lie on the left side rather than being on the right side. And when you consider laparoscopic reduction, when you consider laparoscopic reduction, almost 60 to 90% success rates are reported. The optimal candidate for laparoscopic reduction is a child who presents early onset of symptoms, that is within 36 hours of initial onset of symptoms, without any signs of peritonitis. If you consider the open technique, the incision should be planned according to the position of the intussusceptum, and then after opening the abdomen in layers, you identify the site of the intussusception, and then mobilize the ascending colon out, and then slowly you will have to milk the bowel towards the proximal aspect. You milk the head of the intussusception towards the proximal bowel slowly with gradual pressure. It has to be a continuous gradual pressure, so that bowel injury will be minimal. So you milk the intussusception and give a gradual proximal pressure, and sometimes if it is not reducing properly, you can even give a fraction of the proximal bowel. With this, it will reduce mostly, and after reduction, you inspect the bowel properly. The bowel has to be inspected properly for any areas of tear or any perforation. Usually, in long-standing cases of intussusception, the intussuscipients will be usually dusky. So in that case, you can apply the warm mop and also give 100% oxygen and for 10 minutes, and then again reassess the bowel. Almost 70 to 80% of the time, the bowel will be viable and resection anastomosis will not be required. And when to consider resection anastomosis is another factor which we need to know. That is, if you feel that the bowel is not improving, the color of the bowel is not improving with all these procedures, and even if there is a doubt that the bowel is not viable, then you need to consider resection anastomosis rather than putting the bowel back into the abdomen and risking a perforation in the postoperative period. So the same can be done via laparoscopy also. There we use a standard 3-port technique, a subumbilical camera port and 2 working ports on the left side of the abdomen pointed towards the head of the intussusception. And with a bowel grasper, you can give a proximal traction, and with another bowel grasper, you can try milking the bowel. And the post-production inspection of the bowel is essential even in case of laparoscopy to identify for any tears and also to assess the viability. Also, when you're doing the surgery, you should always see for any leak points, and especially this is important because in laparoscopy, tactile feedback will not be there. So proper inspection is mandatory. So as I discussed earlier, these are the steps of open reduction. So as shown in the figure, this is how you do a manual reduction of the bowel in an open surgery. And indications for resection anastomosis as such, if reduction is not possible and also if the bowel is not viable, then you can go ahead with a resection anastomosis. And if reduction is not possible, then en masse resection has to be done. And if at all even if there's a pathological lead point, you will have to resect it. Coming to the complications, the radiological complications of the radiological procedures involves perforation. Perforation accounts for only 1% of the cases, and performing the enema more slowly and keeping the pressure as low as possible may diminish the risk of perforation. The risk factors include a longer duration of presentation, that is from the initiation of symptoms to the time of presentation at the hospital. If it is more than 36 hours, and especially in infants who are less than 6 months, the risk is always high. Coming to surgical complications, it involves wound infection, facial lesions, and also post-operative small bowel obstruction which can occur due to adhesions or kinks. The complication rates account for 4% without enterotomy versus almost 26% complication rate with enterotomy. Coming to the recurrence rates, they are less common, and I had already discussed the rate of recurrences following radiological procedures and also following manual reduction and resection anastomosis. And the recurrence usually ranges to 15 to 20% for non-operative reduction, and it comes around 3 to 4% for manual reduction, and it is almost nil for resection anastomosis. Coming to the mortality, the reported mortality is less than 1%, and also the interval between the onset of symptoms and institution of treatment is of paramount importance, and the mortality rates will more nearly approach zero the more frequently the more rapidly the treatment is instituted within the first 24 hours of onset. Coming to the outcome, the clinical outcome after treatment of pediatric intussusception continues to be good, and when compared to the compare the mortality rates and the morbidity rates almost 1 century back when the initial treatment for intussusception began, it has almost improved from almost 76 to 80% mortality which was reported initially to almost nearly 1% now. Coming to the summary, intussusception is a common cause of abdominal pain in children, and a thorough history taking and clinical examination for classical signs and symptoms and knowledge of ultrasound. The knowledge of ultrasound helps in early diagnosis and intervention. The success rate of non-operative reduction is high with proper monitoring of the pressure, and it has to be done meticulously. And delay in diagnosis is a primary avoidable factor that contributes to mortality and morbidity in a case of intussusception, and mortality has significantly reduced over the past century. Thank you.
Thank you, Sethu.
Sir.
You were little fast, but then you have done it okay. Well, open for discussion now, sir. Ramchandra sir. Gaurish sir is also there, I guess.
Yeah, Setu, it was a good presentation, but there were major lacunae. Anyway, I will not comment too much because it is going to take too much time. One very important thing forgotten to mention is the newer trend towards daycare treatment of intussusception, which is followed in major centers in China.
Yes.
It was perfected there, the protocol, and now it is being followed in many centers in the US, where there is a high volume caseload. Okay, so you must remember that.
Sir.
That is a newer this thing. Then you completely forgot to mention about Burkitt's lymphoma and other lymphoma, non-Hodgkin's lymphoma, as one of the very important diagnosis for intussusception in older children.
Yes.
Okay, that's very important.
Understood. Yes.
Otherwise, it was good. The operative reduction is described, was originally described by a famous surgeon called as Zachary Cope, who also wrote a book of acute abdomen. It was called as Cope's acute abdomen. So he also described the classical signs of acute appendicitis before surgeons were, sort of floundering to diagnose acute appendicitis.
Yes.
He has made major contribution to acute abdominal surgery, Zachary Cope.
Sir. Okay.
Okay, then there is one innovative technique which was reported long back from Gujarat by I think Shaha and Shahade or something, whereby it is not an on-block resection of intussusception if there is a non-reducibility or if you're suspecting gangrene. They have described an innovative technique. So you have to find out how it is done.
Yes.
Basically, it is done by incising the sheath longitudinally, picking up the intussusceptum apex, putting a big needle and doing a transfixion suture, then pulling out the intussusceptum, and then doing a proper resection. So the gangrenous bowel is taken care of inside the lumen of the intussusceptions.
Yes.
And also you should describe the pathology of an intussusception. There is a entering layer, there is a returning layer, and there is a covering layer. These are the three layers.
Sir.
And the second layer, which is the returning layer, so that has got two hairpin bends.
Yes, sir.
So that is the layer which will get gangrenous first, and the first portion of gangrene will occur in the returning layer towards the apex of the intussusception.
Yes, sir. Yes.
So that has to be clearly understood by everybody. The intussusception is a topic which is almost always asked as a examination question.
Yes.
But as a practitioner also, you should know all the various fine points, all the various nuances of treatment, everything you must know. And your sweeping statement that barium enema is historical, that means that a lot of private surgeons, including me, we are all historical, including Dr. Anil Kumar, who follows me in Sakra. We do maybe sometimes 20 times the number of intussusception reductions you people do in Indira Gandhi Institute. And we still do it with barium enema.
Yes, okay, sir. Yes.
Okay.
Yes, sir. Yes.
So you must remember that.
Sir.
So there are a lot of work being done in the private also, and they are doing good work in the private. Okay.
Yes, sir. Yes, yes.
So that is a very wrong statement to make, that it is historical, it is not used, and all that. And there is one technique which was described in China many years ago, which is called as the inpatient or the ED reduction of intussusception without using any radiology. Just do it based on symptoms. And once the patient is fine, you just chase the patient away from OPD, from the ED, and call them if they are symptomatic. Otherwise, you just say, go and play outside. That's all, finished.
Understood.
So no ultrasound, no fluoroscopy, nothing.
Yes,
Just reduce the intussusception on clinical basis by bedside running of saline. That's all.
Sir. Hello.
Yeah, I'm done. I'm done.
Yes, thank you. Thank you.
Thank you, sir. Gauri sir, any comments, sir? Gauri Shankar sir,
It is done.
he must be driving. Yes.
Yes, sir. Oh, yes, sir. Sir is actually online, but
Yeah. Okay. Anybody has any other questions or doubts? Any comments from anyone?
no, sir.
Okay. As sir told, all the modalities are still used. When we were getting trained at SRMC, we used to do hydrostatic reduction under ultrasound guidance
Sir.
in the radiology council.
Yes,
Okay.
sir. Yes, sir.
So all the modalities are used. It's not like just because we are doing pneumatic doesn't mean that everywhere it should be done. Everything else is obsolete, is not correct.
Yes, sir.
That's one thing.
Yes, sir.
And clinical examination, if the child is having guarding rigidity and things like that, will probably directly go for laparotomy. That is one thing you should keep in mind.
Yes,
Okay.
sir. Yes, sir.
Okay.
Yes, sir.
That's all from my side.
Yes.
Okay. Thank you.
Thank you, sir. Sir, I will end the meeting then, sir. Hello.
Okay.
Sir, I will end the meeting, sir. Thank you, sir. Thank you.